So the next speaker is Rishi Kamaleswaran. Probably said that completely wrong. He's an assistant professor at Emory University in the Department of Biomedical Informatics. And he's going to talk today a little bit about the kinds of things that Emory and Georgia Tech are doing with predictive models.
Thanks so much, Ian. Appreciate it. So today I'm going to be highlighting some of the work we're progressing in the area of implementation, both from machine learning and also some algorithmic stance that we've implemented over the last several months and years. Unique aspects of the work that we've been progressing includes our access to actually a real-time mirror of the entire electronic medical record. There was decisions that were made well before I came on, but there was a lot of hesitation about running machine learning models in the real EMR. And therefore, there was some efforts that went on to replicate the entire medical record. So we have almost a mirror, which is great for some of the workflows and models that we can apply without really having to worry about impacting clinical care at the bedside. So this was something that was something novel, I think, that people were thinking of and progressed, and therefore we now had this resource that could be utilized in a very sophisticated way. We had also developed a series of views and lookup tables and really improved significantly the use of this mirrored EMR, which we call the real-time analytics system, the RTA system, into transforming those low-level data points into actionable products, phenotypes that we can query, and low-level summary statistics that we can use, which were not at all what originated one-to-one in the original EMR, but was actually an aggregation of a lot of different data points. We then had a standalone user interface that was built to allow not only those at the bedside to use this system, but also allowed for operational management at the population level, the measures of statistics, is there adequate resuscitation happening in patients who are identified with sepsis, and so on and so forth. So lots of very interesting use cases came out of this. The system, just as an architectural standpoint, is fairly elaborate. It's excuse the epic notation here. This is kind of where we want to go. But on the Cerner side, we'd have a Cerner system, a mirror that would just feed into this RTA environment. It utilizes these microservice packages, which actually would authenticate to the hospital system. So there was an integral security component in there. And a lot of different services would be running. So we had the sepsis monitor, the early warning system monitor, the decompensation monitor, the readmission monitor, and so on and so forth. So there was a number of different services that were running on that real-time data link, producing information that would then be visualized in the user interface. So one case study that I wanted to point you towards is our success that we had in reducing what we call these unplanned ICU admissions or ICU transferred, broadly termed as code METs, or medical emergency teams. And we'd used that real-time infrastructure to deploy a pilot over several months, and had shown that by implementation of these pilots, of a total of about almost 1,000 alerts that were generated, we saw that almost half of them resulted in an actual transfer to the ICU, which was great, and a sizable chunk, about 20% of these of those code mets were actually likely preventable had there been some earlier identification, some earlier recognition of all of these. And these are some of the reasons as to why we think we could have prevented them. And one of which was discussed earlier, is the inadequate level of data being recorded in the system about patients who were meeting criteria. And providers not having proper cognizance of certain changes that were happening within that appropriate time frame. So while certain data may be being recorded, there was just no feedback loop going back, or an inadequate feedback loop going back to inform providers about what they should be doing and what sort of workup needs to be started. So this is kind of what was going on early during that initial the implementation of this CodeMet team. And so the question that we asked is, could we provide a different avenue utilizing this RTA infrastructure to build a new early warning system that could either improve on this or provide some information about how this electronic system would actually make changes at the low level. The goals of this team was to allow for earlier interventions on patients who are deteriorating in the unit, and there were some units that were selected as a pilot use case over a 3-month period. The primary outcome of interest was just seeing how many numbers of code mets were actually resulting in adequate ICU transfers. Could we improve on what we had done earlier? And then if once this implementation occurs, could we actually improve the ultimate outcomes that were being observed, such as the incidence of acute kidney injury, days in the ICU, intubation, and so on. And what we found when we actually executed this implementation, which continued for a sizable amount of time, was that we were performing fairly well. So out of 220 alerts that ran in one unit, 81 of those required early intervention. So keep in mind that earlier processes were driven by human suspicion, and so it was a manual process of aggregating data, calculating scores, and so on. And when we applied this automated method, we were actually able to show that a sizable chunk of those, even in the early aspects before there were human recognition, a sizable percentage of that required early interventions. In another unit, we had even more. We had almost half of those earlier alerts requiring interventions. And this is seen in various levels in different units. There are some units where there were less number of patients, and therefore there were less number of alerts, but you can see in general that the trend was fairly meaningful. These are some of the interventions that occurred as a result of the earlier warning system. We were not only able to provide medical care in some cases, but actually inform the need for more frequent monitoring. And this, I think, is important, since that one of the earlier findings we saw from the work that occurred in 2019 was that there was inadequate frequency of monitoring. And so by alerting clinical staff that there may be a patient at risk, or just the mere presence of an alert going off to say this person may be at risk, it resulted in additional monitoring that happened, and so possibly led to earlier interventions. Some of the other measures that were impacted were the frequency of labs, the number of medications that were given were also modified, and this is an area that we're looking into to see whether the increased medication regimens had any impact in the sorts of outcomes, and were there other ways in which this outcome could have been achieved without the excessive or extra utilization that occurred, and it's in some cases we actually had actual ICU transfers and procedures like X-rays, CT scans, and so on that were being initiated. So overall, we can see from the administration of the alert, there was actually changes that were going on at the bedside in terms of the clinical staff. And those things were resulting in earlier interventions. More in the same, just digging into some of the detail, you can see here that about 6% of those alerts, about 40 of those 631 alerts, resulted in ICU transfers the same day of that early warning system alert going off, which again is important since this is earlier than human suspicion. We were possibly able to improve or improve the recognition from what it could have been. There's about of the 30 encounters for patients who had recently left the ICU and went back to the ward. One of those required readmission, which I think was important for us to show that we could actually have identified this patient. So these are, again, measures that we were showing in a preliminary phase. The trial or the pilot is still continuing to go on, and there's been updates and improvements to the algorithms, but these are so far encouraging signs. Now, there's a curveball that was thrown to us in the middle of last year that we are now shifting our EMR from Cerner to Epic in 2022, and therefore the infrastructure that we had built will require significant re-engineering. And this is an aspect that we've been thinking about. How do we provide that same real-time capability that was so useful for many of our tasks earlier on within the Epic system? And this is something that we've been thinking a lot about and working with some of our colleagues in other institutions to better understand. So in conclusion, I would say that there's obviously there's significant delays that occur with respect to data collection, and that impacts the frequency of the alerts. And we've shown that by providing alerts that triggers human behavior and therefore increased collection and aggregation of data. We can see here that improving the use of these automated and integrated devices could actually improve our timeliness of the alerts. By increasing the frequency of data recording, we could derive much more accurate estimations of the patient's health status. And then the other aspect is that all of this could not have happened without a dedicated clinical team that could respond to alerts in a timely manner. So some of the discussions that happened earlier on the need for specialized teams, I think is a big learning lesson from the work that we've done. And then one of the things that I think health systems are struggling with today is how do you fund and how do you staff these type of resources, which are not billable in many cases. And so how do you come up with these things? And our vision is that whatever the future is, it should actually consist of a multidisciplinary team where there are data scientists, engineers, clinicians that can work together to advance what we ideally would like to see in improving patient outcomes. So that was a very fast lightning overview, and I'd like to thank the team and also our funding agencies who supported the work and continue to support the work in implementing this tool.